Hi, this is Brian Kim. I'm going to share with you this very first episode in a series I'm going to call Cataract Impossible. Now, there's a lot of cataract surgeons who do a lot of volume of cases, but it's not often that a surgeon encounters a cataract that seems to be impossible to execute safely. Most of the times when we do cataract surgery, we are very confident we can execute the surgery without any trouble. But sometimes you encounter a cataract and you're like, about to start and you just have that little twinge in your stomach thinking, man, I'm not quite sure how this is going to go. I've employed a lot of different techniques to help give me a competitive advantage when I perform cataract surgery. And this case certainly tested my techniques and my skills. And this is why I call this case a cataract impossible case. And this is a perfect first case in this series. And you'll see soon enough exactly what I mean by this. So as you can see, this patient has a dense corneal scar, and this dense corneal scar is due to a herpes simplex keratitis. And you can see it's essentially taking up maybe 1/4 of the cornea. I use a corneal marker, which will help me to center and size the rexus. I make my corneal paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. And so when I first saw this case, I knew it was going to be a challenge, but I still felt very confident in my techniques. And again, it's covering up about 1/4, maybe 1/3 of the cornea. This is intracameral lidocaine and some intracameral epinephrine, and then intracameral air. And this is intracameral trypan blue. You can see I don't push too vigorously, and I'm using the cannula almost like a paint roller to paint very gently the anterior capsule surface, partly also because the visibility is so poor. And I push the trypan blue and air out with dispersive viscoelastic. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me with the cannula, and then I enter. These are the sharp tip Hydrodissection forceps. You can see here now, as I'm beginning to proceed, the view is okay, but it seems like, it's maybe not as good as I was hoping it would be. So I puncture the center with the Hydrodissection and I pull down. I grab the right side of the tear. Thankfully, due to the trypan blue, I do have a really nice view over the cornea where it's visible. But now I'm going over that scar and I just have to trust my technique. And with one grab and rotational movement there, I was able to clear that one quadrant. And then I finish off the rexus, burp some viscoelastic out. And again, that's just trusting your technique, and very important that I didn't re-grab when I was underneath the scar. And this is the Capsulorhexis hydrodissection technique. I place a cannula under the rexus edge contra-incisionally, point the tip down, get a nice wave, decompress, and then sweep on the left side and then the right side. Because I know that I'm pushing the cannula into the meat of the lens, and then I can feel the nudge when I'm at the Capsulorhexis, I know that I was able to place the cannula in proper position and then execute the hydrodissection. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma. And now that the lens material has been moved around, you can see the red reflex is even worse. And so the view is really poor. So I take the chopper under the rexus edge contra-incisionally, the phaco tip vertically sub-incisionally. I'm stabbing into the meat of the lens, and that is the double chop. You can see that sudden loss of resistance, which means I executed a full chop. I place the chopper under the right heminucleus, pulling it central toward the phaco tip, fracturing the right heminucleus, and that is the cross chop. The chopper is cutting the lens against the phaco tip, and the phaco tip is acting like a chopping block. I'm using some vacuum to lift that first quadrant up, and then crushing the lens into smaller and smaller pieces. You will see here, due to the poor visibility, I decided to switch to the dense cataract mode in the middle of the case. And so I'm still in quadrant removal mode, but I'm going to add some longitudinal phaco just to increase my efficiency. I place the chopper under the second quadrant, hooking the peripheral lens. I decide to just separate it a little bit more first, do some separation forces to separate the second quadrant from the rest of the lens, getting around it at the equator, hooking the peripheral lens, pulling it centered toward the phaco tip, fracturing the lens in half. Again, this is a cross-chop maneuver. This case illustrates how invaluable cross-chop is. When you're not able to visualize the lens very well, being able to place that chopper out to the equator, pulling the lens centrally, fracturing the lens against the phaco tip as if it's a chopping block, and then being able to use some vacuum to pull the lens pieces up, as I'm doing here. Lifting the lens pieces up. I'm being very ginger because, again, the view is not very good. The red reflex is very poor because of the corneal scar. And of course, underneath the scar, there is zero view. And so the key is this. I have to bring the pieces into view where I can actually see it, which is, again, more proximal. The distal cornea away from me is very poor visibility. So I have to be able to chop the lens pieces and bring the lens pieces towards me so I can see it, and then very carefully activate ultrasonic energy and vacuum where I'm able to see it. With the dense lenses in particular, you can't take for granted the visibility. You know, when you have a soft lens, you often see that I'm able to disassemble the lens in small pupil cases. But when you're having soft lenses, it's much more easy to disassemble those pieces. With a dense lens like this one, you can't really do that because you have such jigsaw pieces together. So now you see I rotated the second heminucleus counterclockwise, and then I performed another cross chop. Why did I do it that way? Because on that right side of the screen is where I have clear cornea. Normally I would chop contra-incisionally when I performed my lens disassembly of the second heminucleus, but because that area is completely opaque because of the corneal scar, I rotated the second heminucleus not in front of me, but to the right of me. And by doing it that way, I was able to execute a cross-chop maneuver over the second heminucleus, fracturing it completely in half, and then performing more successive cross-chop maneuvers. And then once I have the pieces loose, I'm crushing the lens between the instruments, very controlled with mechanical forces. Again, I have the eye completely inflated. I'm using mechanical forces to crush the lens pieces into smaller and smaller pieces. I'm not haphazardly and indiscriminately applying high vacuum and ultrasonic energy when I'm not able to see. If I did that and I wasn't able to see, you could inadvertently rupture the posterior capsule, and then you're really in big trouble because you can't see anything. So because I'm able to very carefully and very methodically apply mechanical forces to crush the lens pieces, like here I'm performing another cross-chop maneuver over that piece, I'm able to then grab that piece with some vacuum. Again, it's on the right side where I have good visibility, grabbing it with the phaco tip, and then emulsifying the lens pieces. Again, I did go to the dense lens setting because I do feel like I need some additional longitudinal as well as a torsional to help me emulsify these lens pieces. And you can see here, I'm using the chopper to help position the lens pieces into view. I place the chopper around the lens, hooking the peripheral lens, and executing another cross-chop maneuver around that fragment. Cross-chop in this case has become an invaluable technique, and why, once again, cross-chop enables the surgeon to chop from a variety of angles. And so remember, traditional chop requires you to chop contra-incisionally. Contra-incisional to the phaco tip. That's the traditional technique. If I did that with this case, I would be in big trouble. The only way I could have executed it with a traditional technique would perhaps be having a superior approach. I would have to make my main incision superiorly. But you can see here I'm working through a clear corneal temporal incision. And so all I did was adjust my chopping maneuver. The vector forces are not in front of me, they're to the right of me. And so you can see here I'm very carefully, methodically trying to grab the lens with the chopper, hooking the peripheral lens first. And once I hook the peripheral lens, and I'm able to execute the hooking of the peripheral lens, even though the visibility is poor, because I know I can slide the chopper down along the surface of the lens material and up. I'm making sure I'm definitely underneath the anterior capsule when I apply that chopping force. So I take the chopper out, push some more dispersive viscoelastic so that I can protect the corneal endothelium, but also to move those lens pieces into view so I can see it a little bit better. I'm applying another cross-chop maneuver there, as you can see. But again, the visibility here is not that great, but because I trust my technique and I know where I am within the eye with my maneuvers, I can confidently and methodically disassemble and break this lens down. It's like chopping down a sycamore tree. You're just little by little chopping and chopping and chopping, and little by little I'm able to remove the lens pieces. So you can see, in addition to this difficult view, the pupil was never really a big pupil as well. And so right here, I'm trying to grab a little bit of the lens piece that's underneath the chopper. This is an older case. What I would do now is try to hook that piece that's under the chopper with the chopper and get under the peripheral lens and then hook it and pop it back up. But again, this is an older case. I didn't do that. So now what I'm doing is just hydrodissecting underneath the lens under the left side because that lens piece is a little bit stuck. Again, now if I would do the case, I would probably just rotate that chopper under the rhexis edge subincisional to that chopper and then just roll the chopper, hook the peripheral lens, and then it would pop that lens piece up. But in this case, what I did was do some more hydrodissection, and then I did some viscodissection, and I was able to push that lens piece out from underneath the chopper. So I lift the incision, I go in with the phaco tip and then the chopper. And now that lens piece is over the area that I want it to be. I get around the piece with the chopper, use some vacuum, some ultrasonic energy, and then use some crushing forces as well as I very carefully try to remove those last pieces. And you know the last pieces are gone because now suddenly you have a good red reflex. So that was a little bit of the epinucleus that was stuck in the subincisional area. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INE handpiece. Again, that subincisional stuck lens material underneath the chopper was epinuclear material, so it turns out. Because once it came out, you can see a good red reflex, and so I'm able to go to the INA. And you can see the view is just awful, and there's quite a bit of stuck lens material. This polymer tip is just fantastic in general, but also in this particular situation because the view is so poor. I can confidently try to go in and peel the cortical material without worrying about rupturing the posterior capsule. So you can see there's some thick subincisional cortical material that's there. I'm just going after it. And when I'm doing these sweeping maneuvers underneath me, I'm retracting the rhexis edge as I do that. I'm getting under the rhexis edge and just pulling on it so I get under the rhexis edge with those sweeping maneuvers. And then finally I was able to grab that cortex that was in the subincisional area. It would have been very difficult to pulse in the subincisional space, one, because the pupil is small, and also my visibility is not good. I wouldn't feel comfortable employing that particular technique. I wouldn't pulse into the subincisional area when you can't see the rhexis edge. So very carefully but surely, I'm removing the real stubborn cortical material that's within the bag. I'm switching to polish mode and going back and forth between polish mode and cortex, and I feel pretty good about removing the bag pretty cleanly here. So again, I was going to go in with my BSS cannula, but then I decided to switch because I'm not going to pulse. So I go with the cohesive viscoelastic cannula, filling the bag. Of course, in the beginning of the case, I had a bigger size rhexis, but because this is just one of those tough cases, dense corneal scar, dense cataract, and a shrinking pupil, I'm using the Maltzman just to make sure, hey, is my capsule intact? Is the anterior capsule intact? So I'm using the Maltzman. I check the left side first, and then I'm going to go with the lens. So I feel confident that the capsule is intact, and the fact that I'm able to look and visualize where it is. I still have my Provis cannula in there. It helps me retract the pupillary edge, and I pushed a little bolus of cohesive viscoelastic to fill the bag, and then I'm delivering the single piece acrylic lens into the capsular bag and directing it underneath the rhexis edge. I go in with the INA handpiece, activate irrigation once I'm in, and then I also go in with the Maltzman, and I'm going to need the Maltzman to retract the pupillary edge so I can see that the haptics are both within the bag. So there's that haptic, it's stuck to the optic. Made sure I took it off, and then rotating it 90 degrees clockwise, making sure both haptics are in the bag. Again, you've heard me say it multiple times, you need to visualize that the haptics are in the bag, and the only way to do that in this context is to retract the pupil, and you want to get underneath the lens when you remove the viscoelastic. If you don't do that, when the viscoelastic tries to come out, when you're removing it, it could pop the optic out of the bag and potentially the haptics as well, and you don't want the haptic being in the sulcus, especially with a single piece lens. So I take the Maltzman out, I push BSS in with the cannula. Look how floppy this iris is. It's a floppy iris. It's an IFIS iris. And so as I come out with the INA, I want to be mindful of making sure that the iris doesn't come out as well. Thankfully it didn't. And then I hydrate my incision. So again, this is a patient, large HSV keratitis scar covering a third of the cornea, maybe more now. Started off with a bigger pupil and then ended up having a shrinking tiny pupil, also a little bit of a floppy pupil. And you saw how I was able to execute the lens disassembly of this really, really difficult cataract situation, high risk for complication, high risk for posterior capsule rupture. I executed double chop successfully and then multiple cross chops over the right side. Again, contra-incisionally, I couldn't chop and visualize it because there's a dense scar. So I'm able to execute the chop maneuver on the right side where I can see better because I'm able to employ cross chop. And cross chop is just, again, a magnificent, versatile maneuver that everyone should employ and learn because you can disassemble the lens from a variety of angles. And so this patient had a very careful and methodical and slow cataract surgery. You see how long this case is. This patient had very careful lens disassembly, crushing the lens with the instruments, which also decreases use of ultrasonic energy. Despite that fact, you can see the CDE is double digits. And again, that's not my typical because I do such a good job in crushing the lens into smaller pieces, But again, as you can imagine, I had to utilize some longitudinal because I didn't want to take a chance. And so when I had the pieces in, I wanted to emulsify it efficiently. And this is a patient post-op day one. This patient literally had a blinding cataract, and post-op day one, the patient was 20/70 plus 1 without correction and with pinhole 20/40. This patient said this is the best he's ever seen in a long time out of this eye. And again, this is day one after cataract surgery, 20/40. And so despite the dense scar, this patient had a fairly clear cornea post-op day one, very gentle lens disassembly with reduced amounts of ultrasonic energy and vacuum, and being able to fracture the lens with cross chop through that tiny window on the right side of the field. And I was able to very confidently and safely execute lens disassembly. I would challenge anyone if they could do this cataract surgery with the traditional lens disassembly techniques with such a dense scar as this case had. And that is why I call this cataract impossible. Because with traditional techniques, I do think this would have been impossible because you're handcuffed with the techniques. Whereas with cross chop, you are liberated to be able to execute the chop maneuvers from a variety of angles. And so this is why I feel like these techniques allow you to transcend some of the limitations of traditional cataract surgery techniques. And this is why I feel like I was able to go from an impossible cataract situation to a possible cataract situation. So I hope this was helpful to you, and I thank you for your attention.